Dear audience, I am Dr. Didier Verhoeven, a medical oncologist from Belgium, and very happy to present our new webinar, Improving Quality of Patient-Centered Care, in our series Ground Round Breast Cancer Global Quality. Our first speaker will be Nirmala Bhoo Pathy. She is an epidemiologist and public health physician in the Faculty of Medicine of the University of Malaya, Malaysia, champions well-being for cancer patients and family, especially in low and middle-income countries. Our next speaker and discussant of her talk will be Luzia Travado. She is a psychologist working at the Champalimaud Center in Lisbon and very famous for her talks and insights in psychology and patient-centered care. Now, Nirmala, the floor is yours.
Thank you, Didier. Okay, and thank you very much, Didier, for the invitation. I'm really honored. And the topic that have been assigned to me is very close to my heart. So even before I start, I think I just want to give a prelude. Like I'm a medical doctor, and for a long time, I've spent seeing patients in the clinic, and a lot of times my thoughts are always about diagnosing and treating the patients. And I've been guilty of not looking at the patient as a whole person. But in the past decade, a lot of the work that I've been doing and trying to look at patients, especially in the context of cancer, made me realize that most of the time as doctors, we tend to focus on their organs. It sounds shameful, but that's the reality. Like every doctor, when we see the patients, we are interested in their organs. And sometimes we just fail to see that they come from a community, they have a family. And today, that's why I thought it's very important that we put back this concept of looking at patients as a whole and treating them holistically. And in fact, that is the soul of medicine. So I think that it's time for us to revisit and see how we need to inject back the soul of medicine into the practice of medicine. So that's the prelude that I wanted to say. And these are my acknowledgements. Carla Unga and Caroline Taylor are my partners in crime. We do a lot of things around this area together. And of course, a special thanks to the Lancet Oncology Commission, which I'll be talking about in a few minutes. So I think this figure that I'm showing here is something that many of you are very familiar with. Like when patients start, in fact, even before being patients, they have symptoms, the individuals have symptoms, and then they get to the diagnosis, have to make treatment choices, and then they go through several therapy cycles, regime changes, and then they enter what we call a survivorship period. And along the way, sometimes in some unfortunate cases, we have disease progression, and then some patients survive and some patients go through disease progression and they reach end of life. So we call this the cancer continuum. And a lot of the focus is always on getting the patients to the clinic, getting them diagnosed, and making sure that they get the treatment. All over the world, this has always traditionally been the approach and focus. But what we are missing is that wellness in cancer survivors does not only allude to the physical health status or a good health status, but it also refers to the psychological, financial, emotional, social, and spiritual well-being of patients, and also their and their families. And we tend to forget. So it is really timely that we have this new Lancet Oncology Commission that is titled Lancet Oncology Commission on Humanitarian Crisis of Cancer. Now, the title sounds a bit like we are focusing on things in a conflict zone, but it's not really. So just taking a step back, there has been a growing imbalance in the attention and resources that's directed to biomedical and technological aspects of cancer. This is something that everyone is well aware of. So in the last 50 years, a lot of resources have been injected into biomedicine for development of technologies and finding new drugs, which is all great, which is all really important. But what has also happened is there's a relative neglect of the humanistic dimensions of cancer care, about the patients, caring about them, their quality of life, what is important to patients. We have somehow lost that momentum. We have lost in that like focus that we are paying. A lot of it goes to the biomedical aspects. And what this is what the Lancet Oncology Commission has termed as the humanistic crisis of cancer, the new term that we have come up with. And this crisis that we see in this lack of focus on the humanistic aspects of cancer is especially glaring in the low and middle income countries. So the claim of this commission, is this real? So let me give some empirical evidence to back this up. So some time ago in Asia Pacific, there was this effort by the economists to run some high level interviews with key stakeholders in cancer. And they approached several countries. So you can see here Australia, Taiwan, Hong Kong, and many other countries, as well as low and middle income countries like Malaysia, Thailand, China, and India. And what was done during this high level, this stakeholder engagement and these interviews were, we were asking the stakeholders, how do these countries fare in terms of cancer control? And across the cancer continuum, from awareness raising, early detection, and looking at treatment quality and access, and as well as long-term survivorship support, whether they are receiving palliative care, and about data collection surrounding cancer. And from this report card, many of the high income countries did okay. Like if you look across the rows, you can see that Australia got a score of 48 over 60. And of course, the low and middle income countries were lagging behind and getting much lower scores. But what is glaring is when you look at the columns, we see that in long-term survivorship support and palliative care, the scores that most countries did not do well. So a lot of the countries were lagging when it comes to providing long-term survivorship support, palliative care, and also in the areas of advocacy. So when we look at the results from these countries, these are the lowest scores, 44 out of 100, 50 out of 100. So it really shows that we are really not doing well in terms of providing support and care towards patients. And again, we have more empirical evidence. This is a study that I had the privilege to be the principal investigator in Southeast Asia, where we looked at health-related quality of life and psychological distress among cancer survivors which is a cohort study, and we followed up the patients up to 1 year after diagnosis. So in that study, we had, for this particular sub-analysis, we had more than 5,000 patients who were newly diagnosed with cancer. And 1 year after diagnosis, the global health score and the quality of life score was really poor. I wouldn't say really poor, but was low. And 37% of survivors, even at 1 year, had mild levels of anxiety, and 46% showed at least mild levels of depression. So even we would think that in the initial period after cancer, it is understandable that quality of life may be low because patients are just, recovering or going through the treatment and having some side effects. But we would think that at 1 year, things will improve. But our study showed that they continue to have low quality of life and a substantial level of anxiety and depression. And it was linked to cancer stage at diagnosis, of course, but also with age, presence of comorbidities, and linked to socioeconomic factors. And from this study, we concluded that we were not providing enough supportive care for patients that addresses wider aspects of well-being. So we were not giving the support, the psychosocial support that was needed. And therefore, it was thought that this is something that must be raising alarm across the health systems in all the countries that were participating in this study. So even when we look at the domains of healthcare quality, there are six domains, and one of it is actually patient-centered. And it's actually a philosophy or approach to healthcare that emphasizes that patients should be in the middle of, at the heart of care. And are we doing that? I don't think so. So because we started with this patient-centered care, and there are a lot of variations of the way people understand differently what is patient-centered care. So I'm now showing the definition from the Institute of Medicine. Patient-centered care refers to provision of care that is respectful. I think this is a very important one, being respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all the clinical decision. So now we have to take back and think, like when we see our patients, are we being patient-centered? And the other word that I wanted to, like if you are listening to this webinar and you go back and you need to remember two things, please remember the patient-centered care and the definition and needs. So what have we defined needs as? Needs is the level of service or support that patients perceive as necessary to achieve optimal well-being across not only physical aspects, but also psychological, social, practical, spiritual, financial, and other domains. I put in here other domains because there may be other aspects of needs that patients have that have not been captured very well yet. And I know that, for a long time, we have been talking about achieving patient-centered care, especially when it comes to quality improvement cycles, quality improvement processes, because when we talk about quality, then patient-centeredness come into the discussion. But it's always a lip service, how do we achieve patient-centered care? Are we delivering patient-centered care? Because from different settings across hospitals, across countries, people tend to think that I'm doing everything for the patients. Isn't that patient-centered care? So I know this table looks busy, but I just want to walk you through some of the pathways, how can we achieve patient-centered care? So the first step is prioritizing supportive care services as much as biomedical cancer treatment. And in the traditional approach, healthcare services are often focused only on the biomedical aspects. And this goes to diagnosis, treatment, recurrent surveillance, and trying to prolong life. So, looking at survival, how long patients live. So this is the traditional approach. And if we will want to see how can we change this and move towards patient-centered care, then we need to integrate supportive care services to enhance the overall well-being of cancer patients. So in simple terms, it means that you change your mindset from how long people live to how well patients live, or injecting life into cancer, so we also want to know how well people do with living with cancer. And the second pathway, so to do this, to prioritize, and of course, then we need to determine what matters to patients. So what happens is, in the traditional approach, we think that clinical metrics such as survival, recurrence, and adverse events related to treatment and the cancer itself are what matters to patients. Yes, it's true, it's important, but there are also other aspects which are important to patients. And this is what we have called termed as patient-centered outcomes. But what is important here is these outcomes must be defined by patients themselves. And how can we do this? We can do needs assessment with patients, right? And for that, then it comes to the next process, therefore, we need to establish mechanisms to make sure that there is a continuous data collection to identify what the unmet needs are, and trying to monitor the patient-centered outcomes which have been defined by patients. And in the traditional approach, we do not pay attention to this. All our KPI and all our metrics, all in cancer, always revolve around survival, looking at recurrence, and at the most, looking at quality of life, looking at health-related quality of life. So there needs to be a routine collection of data which centers around unmet needs and patient-centered outcomes in oncology practices. And then central to this is there must be co-creation. Co-creation is a very strong word, and I think this is also a very key important thing that we must remember in patient-centered care, meaning that patients are involved. People with lived experience of cancer, be it patients, caregivers, and the relevant stakeholders, they must be involved in the planning of services to ensure that what we deliver in clinical service is really patient-centered. This is something that is not happening yet. I mean, within the research realms, there is a lot of effort being put right now to make sure that the services and even the research that we do is co-created. But there needs to be, there's a lot of room for improvement. And then, of course, once we know that, what patients need, and we get the patients to think together, then the tailoring of supportive care cancer to patient needs becomes easier. And here it is important to remember that what works in one country may not work in another country. And this is where it's so important to take into account context-specific socioeconomic, cultural and health system characteristics. For instance, if we are trying to, like an example that I could give is patient navigation. So we know that patient navigation is a form of service that helps patients stay within the health system. They are directed from the time they have the symptom recognition up to diagnosis and completing treatment, and then also supporting them psychosocially. The patient navigators do that. But what works in the US, for instance, may not work in Asia. So we need to adapt, and which is why the one size fits all approach will not work. It's traditional. We need to move away from that and start tailoring needs. So I've said all these things, but how do we operationalize? What are the solutions? So I'm not going to offer solutions for everything here. What I'm going to do is, pick some examples from different parts of the world to see how we can go towards and achieve patient-centered care. So I said one of the pathways is to prioritize supportive care services as much as biomedical cancer treatment. So what does this mean? So one of the first steps, I think, is when we are looking at national cancer control plans or NCCPs. There must be recommendations on cancer supportive care services in all the health policies and programs that we include, for instance, in the national cancer control plans. And we must aim to organize healthcare delivery to favor the provision of supportive care. Supportive care should not be viewed as an add-on. It should be natural. Like if somebody is going to get treated for cancer, the next step would be they will also be given supportive care, like in terms of symptom management, pain management, psychosocial support, dealing with fear of recurrence, and so on. And of course, to do this, we need to train healthcare providers in the provision of patient-centered care. So let me give an example. So some time ago in the BMJ, there was this publication, happier patients will reduce the cost to the NHS and improve care. And this sort of, focus on news should be something that is in the limelight. We need to say that it's not sufficient to diagnose patients early and give the appropriate treatment, but we must make sure that our patients are well or are happy. And we should not be forgetting the patient's experience amid the efforts, when we are trying to treat patients. Happy patients are the one who will stay in the system, get treated, and not get lost or fall through the net. So we need to re-emphasize this and bring limelight to supportive care. Likewise, the London Oncology Commission that I was talking about, and I'm privileged to be part of, the Commission aims to document the imbalance between biomedical cancer treatments and supportive care services. And we aim to identify drivers of imbalance and provide some evidence-based recommendation and address resource allocation, foster collaboration, and promote patient-centered care. These sort of initiatives, or, these are like high-level white papers. They help health systems to prioritize supportive care services alongside delivery of cancer treatment. So we need to make supportive care really put it in the limelight and make it famous. And that's one of the important things. And then in determining what matters to patients, we need to make sure that our research efforts and quality improvement efforts explore outcomes which are important to patients and what are their unmet needs. So in this instance, studies that have been, being conducted in Europe, for instance, something that Professor Luzia Travado was also involved in, looking at the unmet needs of people living with advanced breast cancer. It was known that patient knowledge gaps, availability of patient-focused information, access to clinical trials, and support and guidance to caregivers and family and friends of people living with advanced breast cancer. These were key unmet needs. So measuring these needs is also part of trying to move and gear towards patient-centered care. And in Asia, we have my group, we have been doing a lot of soul searching, I would say, and it's we start by doing qualitative studies, and we realize there's a lot of emotional needs among people living with cancer. This is not specific to breast cancer. We actually looked at patients with also colorectal, lung cancer, cervical cancer, and so on. And although they were having different sort of cancers, the themes were always the same. In terms of emotional needs, there was a lot of worry on family and young children, fear of recurrence was always there, and it can be so debilitating for patients. And then they were dealing with the physical and cognitive side effects, and a lot of them were saying that they need empathetic patient-physician communication because they felt that the doctors were not listening to them when they wanted to open up to other matters apart from their treatment. And also there were a lot of intimacy and fertility needs. Patients were worried about, like not being able to continue and having more children. And a lot of them have body issues, like they felt that they were not a complete women, they had loss of sexual desire and nowhere to, like ask or get help from. And of course, there were a lot of worries about relationship and marriage. And in terms of financial needs, there was like just overwhelming financial needs, just not because of the cost of treatment per se, but also the non-health costs like transportation, household help, food and daily living. And the thing is that while I'm presenting, it sounds that these are all natural and we should know about it. But looking back at our patient encounter in the clinic, we often don't think about these things when we are talking to patients. We are always focusing, or at least I am guilty, and I'm sure many are, that we always focusing on getting patients treated, but we never think about the other aspects of needs that patients may have. And therefore, it is so important that this sort of studies and this sort of evidence are brought into attention. And of course, now I spoke about financial needs. There are also a lot of employment-related needs because patients have insufficient paid sick leave. And then there's loss of income, not only for patients, but also caregivers. And they face a lot of discrimination, and they have a lot of unmet workplace accommodation needs that is not covered, like they don't get the place to rest and so on. So we need to do that. We need to explore outcomes that important and unmet needs. But then the other thing that I often get from my colleagues is, you ask me to deliver patient-centered care, but I do not have time. Like I only have like 10 minutes to see my patient. And if I delay, I have another 60 more patients waiting outside my room. So what can I do? So I think this is where tools come in. So co-creation of measurement tools to capture patients' lived experience is really helpful. And when we create these tools, we can use them to collect data, which can be self-administered. I mean, all our patients wait in the waiting room for quite some time, at least where I come from. The waiting hours in the public sector is very long. So patients do have time and they can, use that time to answer questionnaires, to say what is important for them. And for here, I just wanted to highlight a tool that we have developed in Malaysia, and it is being also piloted in some of our neighboring countries, which is a needs assessment tool for breast cancer. So we adopted a co-design approach, and it started with a literature search looking at other needs assessment tools for cancer that are present. We got feedback from experts, but most importantly, we have feedback from patients and support groups when we developed the true tools. And we also used a lot of the data that we collected in prior focus group discussion with patients. And based on it's quite a long effort. We came up with a needs assessment tool or a questionnaire with 48 items. And we cover hospital appointments, emotional support, social and intimate relationships, personal care and health, and information and services. And all of these are derived from what patients said. So it is not from the healthcare providers, but it's from the patients themselves. They themselves have identified these are the domains which are important to them. And I'm not saying that we should be using any specific tool that, for instance, that I'm suggesting. There are many tools which are available around. And I believe Luzia would also have some insights on other tools which are available. So here I have just put a number of tools or questionnaires that can be used to assess patient needs. So we have the Need BC from Malaysia, but we also have tools from Australia and Korea. And if you look at the domains, they all are almost always overlapping. These are things that come from patients themselves. And when we use these sort of tools and get patients to answer the questionnaire, patients are able to express what they need. In many traditional societies, patients are still in that mode where they think they should not be asking things which are not directly related to the cancer or the treatment to their doctors. And when they have questionnaires to answer while waiting to see the doctor, we empower them to voice out their needs. And that's why these sort of tools are really great. And these are more details about the tools. So, and the last bit of my presentation. So I was talking about how one size does not fit all, and we need to make sure that whatever intervention that we want to apply one location to another, we would like to make sure that it's adapted. So here, utilization of implementation science becomes very useful, because what we do is we take a intervention model to improve patient-centered outcomes, and we want to apply it to a new setting, then we can do some adaptation. And for this, I would like to highlight the work of my colleague Caroline Taylor from Global Focus on Cancer. And what they did was they adapted a widely replicated cancer peer mentoring model, which is widely used in the USA, to the context of Vietnam. And it was really nice work done a few years ago. And in that adaptation, they did a lot of things. So what they did is they looked at this program called Woman to Woman program in the US. It's peer mentoring. It's a peer mentoring program. And they had a manual. So what they did was they translated it. They also make sure that there's supplemental training materials for peer mentors in various aspects. And even the form of delivery, they made sure that they speak to the people in the local context in Vietnam. And they made sure that the mode of delivery and the channel of delivery was adapted to suit the needs in Vietnam. So there was a training, and mentors were recruited, and the program coordinator made sure that, whatever that has been adopted from the US is fitted to the local population. And together they came up with a new and improved model for the local context, which is called the Stronger Together program. So I invite all of you to read this paper. And even in terms of delivery, the location of delivery, everything was adapted and not directly adopted from the US setting. So this is an example that if we want to deliver patient-centered care, it's not just good enough to come up with or pick some evidence that works from interventions that work from elsewhere, but also to utilize implementation science to adapt that. So these are among the few ways that we can make sure that we deliver patient-centered care. So I would like to end by showing this nice figure, because I think this really applies to everyone. When doctors see patients, we look at them only from the physical aspect, but actually the patient has got so many other aspects that we also need to pay attention to make sure that we have happy or well patients, and therefore they can stay with us and end up with good outcomes. So with that, thank you very much, and thanks for listening. I'll hand the session back to Didier.
Yes, thank you. Fantastic, Nirmala. Perhaps we can directly go to Luzia for her comments. Please, go.
Hello, everyone. Thank you, Nirmala, for such a comprehensive, beautiful, enthusiastic session on improving quality of patient-centered care. I am Luzia Travado. I am a clinical health psychologist specialized in psycho-oncology. I work in Lisbon, Portugal at the Champalimaud Clinical and Research Center from the Champalimaud Foundation, and I am also President Emeritus of the International Psycho-Oncology Society. And I have been working for a long time to improve cancer policies in Europe, to give more attention to patients' quality of life, well-being, and psychosocial care to be included in the treatment and care plan within hospitals that provide this care to patients. So I want to go back a little bit, and this is a photo of the center. It's an amazing center by the River Tejo, seeing the Atlantic Ocean, which also helps patients not to feel so stigmatized, so sick, but gives them hope, which is important that also our structures, our architectural structures also facilitate the journey to the patient. But coming back to your message, Professor Nirmala Bhoo Pathy, which was so important and really makes us understand that we need this shift in the culture of how we practice clinical care, uh, from the biomedical culture to a more biopsychosocial, and also a little bit more pushing to holistic care. So we are in the middle of this movement from just attending to the biological aspects of the cancer, of the disease, and moving to the person as a multidimensional entity with their own preferences, needs, values that we need to accommodate in the clinical care. And so I go back to your definition of patient-centered care. Well, the Institute of Medicine definition that you presented, which prioritizes attending to patients' preferences, needs, and values values the patient as a human and with the human right to make their own decisions about their own health and what they want in regard to their preferences, their values, and what they want to in their life. And as you mentioned, patients nowadays value pretty much not only the quantity, but quality of life. And so we need to attend to the variables, the dimensions that can help patients into having better clinical outcomes that also attend and address these needs. And for that, what do we need? Because this is a shift in culture. So we have to have in our training, and the medical training needs to have this communication skills training, has to learn how to do that, how to accommodate that that difference into my clinical practice. That's not easy. Doctors are used to be prescribing treatments and not negotiating or sharing their decisions with patients. But that's what patient-centered care is to this partnership of sharing decision-making, making a partnership with the patient in which the physician considers patient's values and preferences along the medical evidence to make the best decisions for a given patient in a given scenario. And this relies on the patient-physician communication skills, which may not be yet occurring in the way we would like it to be, because it requires that the physicians elicit and understand patients' values and preferences and their needs and their plans, and also to explain medical evidence, including the risks and benefits of treatments in a lay wording, which is quite difficult for medical doctors also to go from their medical jargon to lay explanations, but it requires that as well. And then to integrate this conversation and the understanding of patients' needs and preferences into a decision that both are comfortable with. We know that when patients understand and when they are integrated into the decision, their compliance increases. So that's also very important for patients' outcomes. And when we are talking about patient-centered care, and I like images, we are discussing all these areas of engaging the patient as a whole person, recognizing and responding to patients' emotions, foster a therapeutic alliance, promote and exchange information, and share decision-making, and of course, enabling continuity of care. But as I mentioned, and I cannot mention it enough, that really good communication improves health outcomes. This beautiful monography done by the National Cancer Institute many years ago shows that the evidence is there that when patients are a little bit more assertive and the systems, the healthcare system is also better organized, and the physicians provide this patient-centered communication, then there is this improved communication in general, which deals, which leads to the improved clinical health outcomes for the patients, not only on the biomedical variables, but generally for the patient. And this is an area that is considered one of the core competencies of all physicians, but has been very much neglected. Some medical educations or medical education already has it very much in the beginning of medical education, but what about continuing education? Do we provide communication skills training? We need to do that so as to help physicians in this challenge of this new type of communication in which I have to encompass a dialogue with my patients and negotiate these treatment decisions to attend to their needs and preferences. Professional organizations such as ASCO has also put together guidelines to motivate and direct physicians on how to do it. What are the protocols? What are the guidelines on how to conduct these conversations? And the global core curriculum for medical oncologists that ESMO and ASCO has put forward since 2016 and have been recently revised already put an emphasis on this education for residents. What about the needs, the patient's needs? Professor Nirmala Bhoo Pathy already mentioned this is of utmost importance to understand what are the patient's needs. And for that, we need to assess them. She showed us some instruments that really we need to know them and we need to assess them to really understand them. And then we need specialists to attend to and support our patients in dealing and recover fully from this disease and treatment side effects. So we need multi-professional teams that do this work of multifactorial rehabilitation, psychological, socially, physically, etc. But for this, of course, we need resources. And for this, we need political will and cancer policies that include this type of care within their framework, their national framework, which should be the National Cancer Control Plans, which is now a WHO requirement for improvement of cancer care and control in the world. And of course, we also need advocacy from our civil society into pushing governments in each of the countries to really put these recommendations forward to attend better to our patients' needs, because doctors cannot do everything. They work nowadays on multidisciplinary teams and have other specialists to attend to the various of needs. And regarding that, I would like to draw your attention to the distress thermometer that was developed by the National Comprehensive Cancer Network since 1998. It's already there, and it's part of this distress management clinical guidelines. This is one instrument that has been validated worldwide that help us on a nutshell to understand what is the level of psychological suffering, the distress of patients, and then what are the physical concerns, emotional concerns, social, practical, and spiritual. And the patients can fill this out in a few minutes while they are waiting. And with this, then we can allocate the resources for the patients and help them deal with the difficulties that they are facing during their treatment and during the phases after. Requirements for best practice in cancer care already recognize that it's essential to have these extended teams that include also psycho-oncologists, physiotherapists, and other specialists in the team to provide the best quality of cancer care possible. Also, the European Commission has also delivered this quality assurance scheme for the accreditation of breast services that also drives on the same way of having specialists to attend to improve better quality of life for patients and also delivering patient-centered care. And last but not least, we now have the privilege in Europe to have the Europe's Beating Cancer Plan and our European Commissioner of Health, Dr. Stella Kyriakides, that for the last years have put immense effort on improving cancer care and control in Europe by placing calls for research, for improving clinical care in all European countries and quality of life and patient survivors care. It's one of the 4 pillars and the centrality of this cancer plan. So we are nowadays in a much better way, but all of us are needed to do this change and in culture and to do this education and to work together to improve really the quality of life for our patients and their journey. So thank you very much. I lead to you, Didier, please.
Okay, thank you, Luzia, thank you, Nirmala. Perhaps time for some questions. I see nothing in the chat in the question and answer, but I have 3 questions, but short answer. Perhaps for Nirmala, the palliative care, as you say, in low middle income countries is perhaps less, but what I say, what I see, there is perhaps more family support of family friends, of nearest and dearest. What I see in high middle income countries, as my countries, that palliative care, it's sometimes taken as a technical issue, as it has to be done, but it has to be done by others, by nurses, by experts in hospices, but there is becoming less supporting of family, of the nearest, of the dearest. And that's what people who are in a bad situation like. So I think a lot must be done by ourselves, by us, and not always organized by the governments. And that's a big issue, I think. What do you think about?
I totally agree with you, Didier. I mean, like the model, we call it compassionate communities, meaning that we get the communities to participate in delivering care, and palliative care is where it's often practiced. It is true. We do a lot of support. We do get a lot of support from the community, but it's also important that the governments recognize them. So while we have a lot of compassionate community activities in the low and middle income countries, but I think there is less interaction between health systems and the communities, and much could be done in that area. So for instance, in some settings, the low and middle income countries especially, sometimes there's a lot of over dependence on the community and NGOs. And this can be bad because what happens is then it means that the health systems themselves think that, like a lot of it can be done by others and they are not moving forward to improve the services. It cannot be that way. So likewise, I can also say the same, we can say a reverse in the high income countries. I'm not exactly sure how well the community support is, but it is also the nature of the community. I mean, in the many of the low and middle income countries, it's a society where there's a lot of dependence from outside the nucleus family, as opposed to high income countries where people are comfortable within their own small circle. So it really depends on the situations where you come from. So while we have more community involvement in delivery of palliative care in some low and middle income countries, if not all, but there needs to be more conversation and engagement between health systems and the community. And there should be a two-way collaboration. And I don't think that is really happening right now.
Perhaps, or if you have a question, Lucia, I want to have a question for you. In the communication between doctors and patients, it it is, as you say, of course, not so easy. An example I give you: how must be the communication if you have an 80-year-old patient more in a geriatric condition, but good by mental good, and you have a treatment. We give 3 months of better progression-free survival. And what do you think you must say then as a doctor? I think perhaps you must not mention that, or you must mention the things we are there and having the big problem as decision to patients who not really can decide, but then to have the idea of, oh, perhaps I missed something, which is not really the case. So that's a very difficult issue, what to say and what must you say and how must you interact.
Thank you for the question, Didier. In fact, patients everywhere are different. So we should not assume that because a lady or a gentleman of 80-year-old does not want to participate in the decision. We need to understand what the person would like the consultation to be. We need to address the patient's agenda. How can I help you in this? What is the person that I have in front of me? You can have an 80-year-old person that pretty much likes you to decide and say, whatever you decide, doctor, it's okay for me. Or a very controlling person that says, what do you have for me? I want to know my risks and my benefits, and I privilege my quality of life. And you have to place it on the table when you have a patient like this. But you cannot do the same thing every time, because there are patients that cannot cope with information. And so if a patient prefers that you don't disclose too much information, you would have to respect that. And that's where it begins, to understand what does this patient want from me and what kind of relationship does this patient want from me. So the first part of the communication is really to understand what the patient already knows about the circumstance, and how would she or he like the communication to go. Because when you ask them this type of question, are you the type of person that likes a lot of information or just the essentials? Would you like to participate, have a more participate role or not? There are these patients that are very passive and you really need to ask the question, but there are those that are more vocal and tell you everything that they need to know, and that makes it easier. But even the passive patient may be, very respectful and do not want to say too much, not to disturb you, but they might need more information than the one that you thought that they would need. So we can never assume. And the real trick of the 21st century is that every one of us cannot assume what the patient wants. We have to ask, what are their preferences? How would you like this to happen? And when you ask this question, the patient knows and already builds a trust in you, because you give them control in the first phase of the consultation. And the person say, okay, my doctor is trying to understand me and he's trying to accommodate the person who I am and what do I need to what is going to happen next. So this is a way of building trust, to really have these essentials in the beginning of the consultation, so then we know what to do next. Is that answers your question?
That's a good, good answer, Lucia. I think we're coming at the end. I like to thank Nirmala and I thank to Lucia for their talks. Very interesting. Thank you. And I
Thank
like to
you.
announce also the next webinar, 21 June. It will be done by Marianka Schmidt with a team. It will be go about genetics in breast cancer, an evolving field with a lot of new evolutions, a lot of very difficult decisions and discussions, what to do, what we know about a genetic background, but to know everything about it, be there 21 June, Marianka Schmidt from the Netherlands with a team of experts. And I like to close the webinar. Thank you all. Bye.
Didier,
Thank
there is a question.
Oh, a question. Oh, sorry.
Okay.
Question. Yeah, the last question, and then we close from my colleague. What if someone say, I don't think this is important and not I'm too busy? Oh, that's not
Okay.
easy.
I think
Very
he's,
short, Nirmala, very short.
yeah. If a person says I don't think that is important, that means they are not delivering patient-centered care, and it's not quality patient-centered care, because quality means putting patient at the heart of cancer care, and when it's not done, it just means that it's poor quality. I think that's the shortest answer I can give.
Okay.
And I would like to place, just to end, an emphasis on education. This comes from the very beginning of medical education, and then
Indeed.
all of us need to undergo on continued education, because communication and doing this shared decision process is a challenge to all of us, and this can improve with learning. And so I would advise everyone to do more communication skills training, because that is very helpful. And thank you for having me, and thank you also to Nirmala and Didier for this lovely talk.
Yeah, thank you, Didier, for the opportunity. It was
Thank
fun.
you. Bye.
Bye-bye.
Bye.